So I haven't put up too many slides. I've only got just under 30 slides, and I thought what I'd do is do a quick introduction on a couple of infections that are common to intensive care, so specific to intensive care. So I'll go through VAP and line infections, and then I'll tell you a bit about the three major pathogens that are, again, fairly not exclusive, but usually associated with intensive care, and just a bit about the background and why they're so concerning when we find them in ICU patients. So I intentionally kept this sort of slide light so that you can ask questions as we go along, and so that it doesn't take too long, because I know you guys are busy. Right, so let's start. Briefly, in infection by number. So this was a point prevalence survey, and it looked at a 24-hour time period in September of 2017, and looked at over 1,000 adult ICUs in 88 countries. And the numbers aren't very surprising. Found that at least 70% of patients were on one antibiotic or more, and this can be treatment or it can be prophylaxis. So So your post-surgical prophylaxis will also count. And about half the patients had either a suspected or proven infection, with just a bit more than that of the 54% with one positive culture. And the types of culture that they got were predominantly gram-negatives, followed by gram-positives, and then followed by fungal infections. What infections are unique to the ICU? So obviously you'll have your ventilator-associated pneumonia because your patients are actually ventilated. And you will also get lots of line-associated infections because your patients have got lots of lines. And this is then quickly followed by surgical site infections, catheter-related urinary tract infections, and multi-drug resistant organisms. So that's not a particular infection, but it's a problem that's associated with intensive care unit, because ICU patients are more likely to develop infections with multi-drug resistant organisms compared to patients elsewhere in the hospital. And why is it that patients in ICU are more prone to these infections? So first of all, with ventilator-associated pneumonia, the fact that you're ventilating the patient in the first place predisposes them to VAP. And with the rest, it's really regarding the patient factors that you have within the intensive care unit. So if you think of most patients on the ward, they will be mobile, they will get up and about. Some of them will shower, even if not every day. They will have a bath or a shower at some point during their stay, or they will get bed baths. And their environment is not as you don't have an area where you get lots of patients coming in and out of the same frequency as you do on the ICU unit. On ICU, your patients are immobile, so they are more prone to respiratory tract infections anyway. They may shed skin cells into their environment, and because they're not up and about, they're not getting a shower every day, etc., their environment are more likely to be more heavily contaminated compared to the ward patients. Also, ICU is a place where you do lots of invasive procedures on patients. You put lines in frequently, not just one, but several, then you ventilate them. So you've got lots of invasive procedures, and you've got lots of plastic that's inserted into the patients, either via your ET tube, your catheters, or your lines, really. And the third factor is that we use lots of antibiotics in ICU. So all that in combination then predisposes patients to more infections and more resistant infections as well. So ventilator-associated pneumonia, the definitions, I'm sure you're familiar with this. This is pneumonia which develops more than 48 hours after intubation and mechanical ventilation, and it can't be present before intubation for it to be classed as a ventilator-associated pneumonia. And how we look for it, so you're familiar with how we assess this during the MDTs. We look for new or worsening pulmonary infiltrates on their chest X-rays. We look for systemic signs of infection. So raised white cell count, fever, etc. Plus, we also look for a growth of a pathogenic organism from their lower respiratory tract. So not sputum, this is an ET aspirate, or even better still, from a BAL sample. So if you pay attention during the MDTs, you'll notice that sometimes we grow something else. And I asked the question, how's the chest? The reason I ask it is because I have noticed that we have a sample, either an ET aspirate or BAL, and we get quite often a gram-negative from that. And one of the consultants will say, well, no, I'm not worried about them. White cell count's fine, haven't got fever. The physiotherapist might say they've not noticed increased secretions, and then we don't treat them. But conversely, if they do have signs of an infection, then we will treat it as a VAP. I'm trying to coordinate two slides here. So organisms that cause VAP. You get your usual Staph aureus. That can be MRSA or MSSA. We also have strep pneumoniae, which is a common cause of respiratory tract infections, and that is the same whether they are ventilated or not. So strep pneumo is still a major culprit. Haemophilus influenzae is the other one. Again, patients don't necessarily have to be ventilated to have H. influenzae, but ventilated patients are at higher risk. And also patients with known chronic lung disease, excessive alcohol use, and smokers are known to be associated with H. influenzae infection. And the other two, Pseudomonas aeruginosa and Enterobacterialis, are very sort of VAP specific type organisms, because these are ITU associated pathogens that are implicated in VAP. So Pseudomonas aeruginosa especially, because they like plastic. So if we've got an ET tube in, then a pseudo infection can be a real troublesome cause of that. Enterobacterialis are all your other coliform gram-negatives. So that includes E. coli, Klebsiella, which are your two most common ones, and Proteus, which is a bit less common as a cause of that. We get a lot of Candida. So if you send an ET secretion or you send a BAL sample, you might see Candida, more commonly ET secretions, not so commonly in a BAL, which is taken from a deeper source. This is likely colonization. It is not a common cause of that. It doesn't tend to cause invasive pneumonia. So we wouldn't treat a Candida that you find from a respiratory tract sample. However, having said that, because Candida likes plastic as well, forms biofilm. So if you have heavy Candida colonization of the ET tube, it actually forms a really good surface for a secondary bacterial colonization, which then subsequently causes a bacterial ventilator-associated pneumonia. So it's not in itself a pathogen of VAP, but it can promote VAP from secondary bacterial infections. Treating Candida in respiratory specimens is not going to help you, because if you have a heavy colonization and the ET tube is covered with biofilm, your antifungals aren't going to be effective against that. And how do we manage it? So the actual treatment for ventilator-associated pneumonia is going to be antibiotics. And the antibiotics need to target your common causative organisms. That's why we use piperacillin, tazobactam, or tazocin as first line for VAP management in the hospital, because it has pseudomonal cover, whereas your co-amoxiclav doesn't have anti-pseudomonas activity. The other steps are all in terms of are all helpful in terms of prevention of that, but you can't actually use them for the treatment. So aspiration, suctioning of your subglottic secretions, good oral care. This is all about reducing your bioburden of bugs that then get into the lungs and cause your VAP. Positioning and encouraging mobility, and minimizing ventilator exposure or duration. So this is what you're trying to, when you do your sedation holds and you try to get patients, when you try to wean off the ventilator, this is all steps that actually do reduce the likelihood of VAP developing. Some of you may have heard or read about using chlorhexidine oral mouthwashes for patients. And there are some studies that show that they can reduce the incidence of VAP, but there was quite a big appraisal that was done in Canada in 2019, which showed that it was effective for cardiac surgery ICU patients, but not so much for patients that are not part of the cardiac surgery cohort. And the cardiac surgery cohort tend to stay on ITU for a shorter duration, so that may have skewed things slightly. And there was a slight increased mortality in the other patient groups, apart from the cardiac group as well. So the jury's out, and there's hesitation to recommend it within the guidance for oral care in ICU units. There are some thoughts that there is a risk of aspiration of the chlorhexidine, especially in ARDS patients, which then leads to chemical pneumonitis, which actually makes things worse. But that's not proven at the moment. So next, you have your line-associated infections. And these are just some definitions, because you might have heard some of these phrases being used when we talk about line-associated infections. So phlebitis is inflammation along the track of the vessel that the line is in. And when we talk about exit site infection, this is where wherever your IV catheter is coming out the skin, within 2 centimeters of it, you're getting inflammation, you're getting redness, you're getting exudate from it. So that's your exit site infection. If you have a tunnel line, such as a Hickman line, then the inflammation is more than 20 centimeters from your exit site, and it follows the subcutaneous tract of the CVC. There is also pocket infection. This is related to ICDs and pacemakers, so you see a bit less of that on the ITU at the Royal. And there is also catheter-related bloodstream infection, so that's your cryptC. So that's bacteremia or a fungemia, usually a candidemia, as a result of an infected IV catheter. So your causative organisms for your line infections, it's most likely to, as per outside of the ITU, to be either a Staph aureus or coag neck staph. So your Staph aureus can be either an MSSA or it can be an MRSA. And MSSA stands for methicillin sensitive Staph aureus, so that's your box standard Staph aureus, and MRSA is methicillin resistant Staph aureus, so it's the multi-drug resistant Staph aureus. And coagulase negative staphylococci are your skin commensals, so your Staph epidermidis, Staph hemolyticus, etc. But on the ICU, you also have these other organisms that may cause line infections. So your Enterobacterialis, like I mentioned previously, E. coli and Klebsiella. Again, Pseudomonas, our friend there. Enterococcus is a gut organism, but can cause line infections on ICU, especially for lines that are femorally placed. So those vascas that sometimes do get enterococcal infections. Candida, skin organisms, but again, on ITU, patients have a higher skin burden of their commensals, and also patients who have intra-abdominal infections and lines, they're at higher risk of Candida infections, and patients on TPN as well. And I've also put Malassezia, which is a yeast, and I've put TPNs in bracket because Malassezia loves fat. It's a yeast that in the lab, we can't grow it unless we put some oil on the plate. So if we see a yeast on the gram and it doesn't grow on the plate, we then add some olive oil onto the culture plate and try and grow it again. And if it grows, it's likely to be a Malassezia species. And patients on TPN, especially on a high dose with a high lipid content, are at risk of a Malassezia infection because it's a skin organism. It's the one that causes pityriasis skin infections. So how do we manage line infections? In terms of investigations, paired cultures are what we need. And the reason we do paired cultures is because the time to positivity can help us determine if the line is the source. So what's time to positivity? This is when you do paired culture. So the line culture and a peripheral culture needs to be done at the same time or as close as possible within a couple of minutes of each other. And both sets need to have the same volume. So if you put the same volume in the peripheral culture and the line culture, and then you incubate it, then if the line culture flags positive more than 2 hours before the peripheral culture does, then that is by definition is a line infection. And this definition is used, is universally acknowledged. The other way to do it is to do colony counts, but that's extremely difficult to do. So time to positivity is what most places use to determine if this is a line infection. But this is only possible if you actually do the PET cultures, and it is only accurate if you do it at the same time and if you put the same amount of blood volume in each sample. So if you have confirmed a line infection, then line removal is best. If you see an exit site infection, then again, you don't have to wait for the cultures to come back. It's a clear exit site infection. You should just take the line out. We get tips sent to us in the lab quite often. I would ask that you only send the tip if infection is suspected, and sending the tip is not a replacement for doing PET cultures, because that should come later. If you do PET cultures and you send the line tip, that would help us determine properly if that's a line infection. If you just send the tip, I won't be able to tell if that's a line-associated bacteremia or is the tip infected because at the time of removal, it's touched the skin surface and picked up skin commensals. In terms of treating line infections, vancomycin is what we usually use for first line, and I've put unless you're suspecting an unusual pathogen. So if the patient's known to be colonized with Pseudomonas or Candida, or we've had issues with gram-negatives before in that particular patient, then you might want to broaden the cover a bit at that time, especially if the suspicion for line infection is related to rigors and with line use, and you don't see an obvious exit site infection. Because if you see an obvious exit site infection, it's most likely to be Staph aureus related or some other gram-positive, in which case vancomycin would be perfectly adequate cover. In some specialties, such as your long-term nutrition patients with TPN lines, we sometimes attempt line salvage because these patients need a line for life, and we need to try and preserve each line that they have. So line salvage can be attempted for low virulence pathogens. So low virulence would be your coagulase negative Staphylococcus. It wouldn't be appropriate for Candida infections. It wouldn't be appropriate for Staph aureus infections. And on ICU, this is rarely appropriate for your patients. But again, you tend to deal with central lines rather than tunnel lines in these patients. The way we salvage the line is that if they are not systemically unwell, then we lock the line with vancomycin or teicoplanin, and we aspirate the line every 24 hours and then lock it again with more antibiotics, and we carry on for 2 weeks. But you won't be able to use the line very much during the line lock, because the idea is that you want to leave the antibiotics to dwell in the line for as long as possible. So that's why it's not appropriate for your ITU patients, because the reason they have a line is because you actually need the IV access immediately. So that's that and line infections. And then I'm going to go through a few of the organisms that I think you should know about. So the first one is Pseudomonas aeruginosa. This is the one that scares me the most because it's very difficult to deal with. So you've got a gram stain there of long, slender gram-negative bacilli. Pink is gram-negative, and that's how a Pseudomonas usually looks like on the gram stain. That's of a pure culture. On blood agar, it looks, it's got this slightly green tinge that you can't see very well, but it's quite mucoid looking. It's quite a wet looking organism. And then at the bottom there on the picture, you see that it's quite greenish in color on nutrient agar, because Pseudomonas produces pigments, and pyocyanin is one of the pigments that it produces, and it's blue-green in color and water soluble. So that's why it's got that blue-green tinge. And you sometimes hear consultants and nurses talking about wound infections, and say, oh, I think that's a Pseudomonas in the wound because it's got a slight green tinge to it. That's because the Pseudomonas is producing that pyocyanin. It's got lots of survival mechanisms, Pseudomonas, which makes it which makes it very virulent, actually. So it's an environmental organism. It's found in soil, it's found in water, it loves humid environments. And it's a bug that loves plastic very, very much. And it forms biofilm. It forms biofilm on biotic surfaces. So biotic surfaces are living surfaces such as skin and heart valves and things like that. But abiotic surfaces as well, such as plastic. Pseudomonas is capable of forming biofilms on both, especially on abiotic surfaces. It's got a high level of intrinsic resistance. So the Pseudomonas has got very low outer membrane permeability. So it's got a very, its outer cell membrane is capable of repelling lots of antibiotics and not allowing your hydrophilic antibiotics like beta-lactams from getting into the bacteria in the first place. That's why a lot of antibiotics don't work against Pseudomonas. It's also got the ability to upregulate its efflux pump, so it can pump antibiotics out actively. And it's also got lots of inactivating enzymes that it can upregulate production of, such as beta-lactamases. And it also has the ability to acquire adaptive resistance mechanisms. So it can take genes out from other gram-negatives in the environment, and it can also have lots of mutational changes. So this kind of plasticity means that Pseudomonas is capable of developing and acquiring resistance even on treatment, and it makes it very difficult to treat because this happens very quickly in Pseudomonas compared to other organisms. So you can see clinical failure within the course of treatment. I'll illustrate that with a case study in a bit. I mentioned earlier about Pseudomonas being an environmental organism. This bug has the ability to use very simple organic molecules, such as just carbon as a fuel source. So because of that, it can be found in areas that you think bugs shouldn't grow. We had an outbreak, I think it was 2016, 2017 in the East Midlands, in the Midlands, and then somewhere down south in the UK as well, of Pseudomonas ear abscesses, and this was traced to be related to a aftercare saline solution that was being sold by places that did ear piercings. And a whole batch of them were contaminated with Pseudomonas, and people were presenting with these horrible infections of their piercings because these saline solutions, which doesn't have very many nutrients in them, it's salt water, but Pseudomonas was thriving in it, and a whole batch was contaminated with it. So this is a picture of Pseudomonas on a biofilm, and what a biofilm is lots of polysaccharides, proteins, lipids, DNA material. It's all caught up in an extracellular matrix, really, and Pseudomonas then forms a layer on it. And in this picture, it shows you a bit about how biofilms form. So you get in one an initial attachment, and then the attachment becomes stronger. And at this point, the attachment is irreversible. You can't clear the bugs off the surface. And the biofilm then carries on maturing. So in 3 and 4, these are maturations. So what happens as they mature is the cells at the bottom, the bacteria at the bottom, then go into a dormant state. So their only function is to ensure survival of the biofilm. So they don't have lots of metabolic activity. So your antibiotics aren't going to work against them, because antibiotics work by halting metabolic processes like cell wall repair, cell wall building, protein production, etc. Because the cells at the bottom of the biofilm are completely dormant, your antibiotics aren't going to work against them. The ones at the top, their function is dispersion and spread of infection. And so these are highly metabolically active. So the MIC, the minimum inhibitory concentration that you need for any antibiotic to act against a biofilm, increases rapidly as you go deeper down within the biofilm. And with biofilms, what all these organisms are doing is they are acting as a single living organism, if you like. They've all got specific functions. Some might be to produce more of the extracellular matrix, etc., and some would be to continue metabolic activity for the survival of the entire macroorganism in the biofilm. And what this means is, without source control, without removing the actual source of the infection, we can't really treat biofilm-forming infections effectively with antibiotics. So what infections are Pseudomonas associated with? You've got your bloodstream infections, hospital and ventilator-associated pneumonia, because you've got ET tubes in there. And again, catheter-related bloodstream infections and catheter-related UTI. You'll notice that 2, 3, and 4 are all most likely because you've got plastic in the patient, and your bloodstream infections can either originate from your VAP or your lines. And sometimes it can be in the gut, so you can find Pseudomonas in the gut of some patients, usually because they've had hospital stays and been exposed to antibiotics. Which antibiotics work for Pseudomonas? You've got your in terms of penicillins in the UK, we really only use piperacillin, tazobactam, so tazocin. You've got some cephalosporins that work. You've got carbapenems. Then quinolones would be cipro and levofloxacin. Aminoglycosides, amikacin and tobramycin. Gentamicin is no longer considered suitable according to latest guidance, but aminoglycosides aren't great for getting into the chest, so we don't tend to use them for pneumonias. And then others are astrinam and colistin. So you think this list sounds like a reasonable number of antibiotics that would work against Pseudomonas. However, you actually get resistance as you are treating the patient. So you can very quickly exhaust this list of antibiotics, even in a single patient. And I'll illustrate this with a case study that of a patient that we managed on the ICU around 2020 at the beginning of the COVID season. So the COVID pandemic. This was a 58-year-old woman at the time, and she came in with type 1 respiratory failure, having had a cough at home, and was intubated and ventilated very quickly in resus, and then came to the ICU at the LRI, and she was positive for SARS-CoV-2. This was her chest X-ray at the time of admission, and it's very typical for our COVID patients at the time. So at the top of this is all the drugs that she had in her 157 days, or not all the drugs, or the antibiotics that she had in the 157 days that she was on the intensive care unit. She was at the LRI for a while, and then she was transferred over to the ICU at the Glenfield. Very early on in her admission, we grew a Pseudomonas from her CVC tip. And at this point, it was really only resistant to astrinam and meropenem. And the resistance to meropenem is one of the first to develop because the Pseudomonas upregulates an efflux pump, which is a pump that actively pumps meropenem out of the Pseudomonas. So then it becomes ineffective. But we still have quite a lot of antibiotics that we could potentially use for this patient. And then not a few days later, we find some Pseudomonas in her sputum. This didn't get any sensitivities because it was a sputum sample. It was regarded as upper respiratory. On hindsight, it would have been an ET sample. It just wasn't labeled properly. And then we got a tracheal aspirate about 30 days in, and it is now a lot more resistant. You've got resistance to your astrinam and meropenem, as you did previously, but it's now resistant to cephalosporins, ceftazidime, to your penicillin, your piperacillin, tazobactam, and your quinolone, ciprofloxacin. So now you've got amikacin, but that's useless in the chest, so we don't use it. You've got ceftolozane, tazobactam, but in 2020, we didn't have any because there was a contamination issue and all of ceftolozane, tazobactam was withdrawn from the market. You've got colistin, very nephrotoxic. You've got ceftazidime, avibactam, which we did use eventually. And nettlemycin, again, not suitable for the chest, and tobramycin. And then we very quickly, so she very quickly found that she had an empyema on ultrasound, and she needed a chest drain put in, and it was recommended that she had thoracic intervention to try and get some source control for this. But there was a fear that because of the COVID, she wouldn't get through the procedure successfully. So the thoracic surgeons wanted to wait for a bit. So we waited and popped a chest drain in, and you can see now your Pseudomonas is a lot more resistant. You have lost your sensitivity to ceftazidime avibactam and ceftolozane tazobactam, even though we didn't use it because the genes all sit very close to each other. So if they upregulate one, they upregulate the rest as well. And we're now left with the options that are very nephrotoxic and the ones that don't get into the chest terribly well. Tobramycin does, but it's quite hard to give. So what did we do at that time? This is a simplified, day 75 is a simplified version of all the resistance. I didn't add in the rest, but they were all resistant as per day 63. There was a new antibiotic that was not available widely on the market yet. We went to the drug company and said, look, we've got this patient. We think that your antibiotic cefiderocol would work. Can we get someone on a compassionate use basis? So she was the first patient we used cefiderocol on in the hospital. And at that time, they hadn't even sorted the antibiotic sensitivity interpretation properly yet, but we had to cobble something together, and we tested it, and it looked acceptable, and we gave it to her. But around the same time, she also managed to get to the Glenfield for the thoracotomy and decortication. So the combination of her source control and mopping up the residual infection with cefiderocol seems to have worked for her at the time. She carried on having a very resistant Pseudomonas. But we did manage to get her out of hospital after 150 days. And from all accounts, she was seen back in clinic again and was doing fairly well. I've not noticed that she's come back into hospital since. Okay, the next bug I want you to know about is Acinetobacter baumannii, which is like Pseudomonas, it's an environmental organism. However, Acinetobacter species on the whole are environmental organisms. Acinetobacter baumannii specifically is usually found in hospital environments, and it's very often found on intensive care units. It's an opportunistic and hospital-acquired infection, meaning if a patient's got an Acinetobacter infection, they almost always get it from hospital. And patients who are immunocompromised or have lines are at highest risk of Acinetobacter infections. It's associated with battlefield trauma. So we saw a sudden increase of it after the Iraq War, when military personnel from military hospitals were repatriated back into civilian hospitals, and that caused cross-contamination into civilian hospitals as well. And now it's found in most hospitals. It colonizes the skin and the oropharynx of infected patients. And the reason why this bug is so difficult to treat is because it's got extensive resistance to most first-line antibiotics. And the other thing is this bug is very able to acclimatize to any changes in its environment. So it responds very quickly, like Pseudomonas, to environmental pressures. So it upregulates its innate resistance mechanisms. And also it's got the ability, again, like Pseudomonas, to acquire foreign resistant determinants. And these usually sit on plasmids. So when these bugs take up resistance genes that are located on plasmids, they don't just take up one resistance gene. These genes sit on what we call gene cassettes, and they are multiple genes which confer resistance on a single cassette that then sit on a plasmid. And sometimes you can have more than one cassette on a plasmid. So it's a bit of a download of resistance information that these bugs get when they do come across a resistance plasmid. it's very able to resist desiccation. It persists in the hospital environment, and it can form biofilm, again, like Pseudomonas. So you're getting a bit of a theme here. The bugs that cause the most problems are those that can form biofilms, and those that are able to mutate and evade antibiotics very quickly and upregulate the resistance mechanisms. I've talked a bit about intrinsic resistance. You don't need to know the details, but these are intrinsic resistance it's enzymes that these bugs have intrinsically that confers high level resistance, and also the genetic plasticity that I talked about, the ability to facilitate quick mutations and take up mobile genetic elements that confer resistance. It's associated with VAP. It's also associated with community-acquired pneumonia, not so much in the UK and Europe, more in Asia and Australia. Associated with bloodstream infections. I mentioned battlefield trauma and wound infections. It actually causes a type of skin and soft tissue infection, which is quite specific to Acinetobacter. But you really only see this in military personnel, so we wouldn't see very much of it. And it can be associated in meningitis. Again, we don't see very much of it because I think we're not a neurosurgical center, but in ICUs where you have lots of patients with neurosurgical shunts and plastic, Acinetobacter meningitis can be a real threat. And then last organism I want to tell you about is MRSA. Most of you are aware of what it is. So it's a resistant Staph aureus. It's a Staph aureus, effectively. It causes the same infections as Staph aureus. However, this particular Staph aureus has extra resistance to it. We identify it in the lab by using cafoxetine sensitivity testing. If it's resistant, then that's an MRSA. But in practice, what this means to you is your first-line beta-lactam antibiotics that you use for skin and soft tissue infections, such as flucloxacillin, coamoxiclav, etc., will be ineffective. Your patients can be colonized or infected with MRSA. About 3% of the population is colonized with MRSA. When it comes to MSSA, which is methicillin sensitive Staph aureus, that number is about 30%. Colonization is of the skin. And your transmission is via fomites. So fomites are skin cells that contain bacteria, essentially, that shed into the environment and contaminate the environment. So that's fomite contamination. So transmission is via fomites and possibly healthcare worker contamination as well. So there was a study that they looked at what they call the USA 300 strain of MRSA, which is a community strain in the US that has gotten into the hospitals. We luckily do not have that strain here. And looked at healthcare workers before and after they went into known infected MRSA patients' rooms. And they found that even before going to the room, some healthcare workers were already contaminated because they were not doffing properly from other patients when they came out of their rooms. And contamination was also found on hands of healthcare workers, clothes, their cell phones, stethoscope, patients' sign-out list, and doffing mistakes were thought to be one of the main issues there. So MRSA is not any more transmissible than MSSA. The transmissibility is about the same. The difficulty is that it's resistant, so it's harder to treat. And MRSA bacteremia figures are monitored nationally, but in terms of the types of infection it causes and transmission, it is the same as Staph aureus. We've had issues with MRSA outbreaks before in the past, and then we have gone to decolonizing the whole unit, etc. I've mentioned about healthcare worker contamination with MRSA. It's very difficult to screen healthcare workers because the interpretation of the screening is difficult. Healthcare workers can be transiently colonized with MRSA. You may start the shift not colonized, end the shift colonized if we swabbed, and then start again the next day not colonized. So it can be transient, and just because a healthcare worker is colonized, you can't tell if this is a long-term colonization, if they're actually carriers, or is it because they've picked it up from the environment of having worked on the ICU unit. So if there is an outbreak, we tend not to screen healthcare workers unless we cannot find any other source anywhere. And even then it's a bit of a fraught thing because interpretation is extremely difficult. Infections that are associated with MRSA. So these will be the same infections that Staph aureus cause, which are bloodstream infections, catheter-related bloodstream infections, your catheter-related urinary tract infections, skin soft tissue infections, obviously, because that's where your Staph aureus tend to cause the most problem. Prosthesis infections, so artificial joints, heart valves, cardiac devices. It can cause pneumonia. Tends to cause, it can cause pneumonia, more likely to be a VAP compared to, say, a community-acquired pneumonia, because this is a healthcare-associated infection. And if we get either an MRSA bloodstream infection or a Staph aureus bloodstream infection, then we will do a post-infection review for that patient. How do we mitigate risk? So screening, I've talked about. We decolonize patients on the intensive care unit. And they're considered MRSA free if they've had 3 negative screens that are done at different times. However, the screens should only be done more than 48 hours after you've stopped decolonization, because you need to know if the screen is negative because the patient still has decolonization on board, or if they're truly clear from it. We isolate patients and we have contact precautions for patients that are MRSA positive. And this, this is very basic, but if your patient's got a skin disease like eczema or psoriasis, that means that they are at higher likelihood of shedding fomites, then the risk from these patients are higher. In terms of what you need to be aware of, you need to be aware of your patient's MRSA status when prescribing. If you have a line infection, your patient's got cellulitis, if your patient's MRSA positive, you wouldn't reach for the flucloxacillin. You would go to something like vancomycin with MRSA cover. And talked about, so what antibiotic to use? Generally, we'll use a glycopeptide like vancomycin or teicoplanin, but linezolid and daptomycin does have activity as well. Some antibiotics that are known to be used for MRSA infections like clindamycin, doxycycline, and cotrimoxazole. I would only use them if you've got sensitivity testing, because that sensitivity can be variable in patients. Quickly, PVL. So PVL is a particular toxin in some strains of Staph aureus. The strain can be an MSSA or an MRSA, and you get a necrotizing pneumonia with it, or recurrent skin soft tissue abscess. They don't tend to present together, either pneumonia or the skin abscesses. It's very highly transmissible, and when we treat them, we give an antibiotic with an antitoxin activity as well, such as linezolid or clindamycin, but that's usually on specialist advice. And we would try to decolonize these patients, even if it's an MSSA, but it's very difficult. Quite often decolonization fails. Last few minutes just to tell you about ICRIP, if you don't already know about it. So this is the Infection in Critical Care Quality Improvement Program, and some of our units are signed up to it. So this looks at bloodstream infections on ICU and produces a quarterly unit level report so that you can benchmark yourself against other units. It used to be voluntary. It is now in the service specs for adult intensive care, but I don't think it's mandatory, and not everyone is signed up to it yet. There are thoughts about wanting to make it mandatory, but it is good practice, and I know certainly the Royal ICU is signed up and part of it. Last slide, take-home points. Lots of bugs in the environment because it's ITU. So try not to move the bugs around either on yourself, equipment, etc. And antibiotics treat your patients, but they also increase resistance because you're exposing the bugs to the antibiotics, and they can then upregulate their resistance mechanisms towards it. Bugs love plastic, so if you don't need a line, please take it out. And if it's there but it's not causing a problem, then keep an eye on it, because giving antibiotics for something that's not actively causing infection can actually cause more problems than it solves. That's me done. Any questions?